Okay, good afternoon. I think we're going to get started. It is with great pleasure that I get to introduce Dr. White, our speaker. Dr. White is currently Emeritus Professor of Clinical Medicine, recalled and currently actively practicing medicine in the Department of Medicine and the Division of General Medicine, where he served as Chief of the Division for 20 years from 1997 to 2017. Dr. White obtained his MD from Washington University in St. Louis and then did his residency in internal medicine in the Department of Medicine at UCSF. He then did a fellowship in general medicine before moving to UC Davis in 1980. In the late 1980s, Dr. White and Jeff King, PharmD, spearheaded an effort to create an anticoagulation clinic, which were just emerging on the national scene. The only anticoagulants then were heparin and warfarin, and the only indication for anticoagulation were venous thrombosis and the presence of mechanical heart valves. Nevertheless, the difficulties of managing warfarin therapy were well known, and it was very clear that the residents in training were not capable of adequately managing their patients on warfarin. In the 1990s, the anticoagulation clinic grew quickly as the INR became the test of choice, AFib became a major indication for anticoagulation, and new drugs hit the market, especially low molecular weight heparin, fondaparinux, intravenous direct thrombin inhibitors, and several other drugs which have since been pulled from the market. An in-hospital anticoagulation service was started by Bill Dager, PharmD. The service grew from 5 PharmDs that followed 2,500 outpatients and over 70 inpatients at any time. With the advent of new direct oral anticoagulants, DOACs, we are now in a new era of anticoagulation care, with less of a need to monitor the dosage of patients, but more of a need to educate and monitor the adherence of patients on these DOACs. It is with great pleasure that I now get to turn it over to Dr. White, who will talk to us about these anticoagulants.
Thank you very much, Jamie. Yeah, it's a pleasure to be invited by Jamie and be able to talk to you about anticoagulants. It's, of course, something I have a lot of passion about. Let's stop and think a little bit about why anticoagulation is so interesting and why a lot of people share that kind of interest. And I think it boils down to the fact that it's probably, for most general internists, the most dangerous drugs that we prescribe. So there's this inherent risk attached to starting someone on an anticoagulant, and you feel really bad when you give the patient the anticoagulant and they have an acute intracranial bleed, et cetera. On the other hand, if you're treating someone to prevent something like stroke with AFib, and they do well for many years, you've got the solace of knowing that you've instituted an appropriate therapy and that they've had no complications and maybe have a much better lifestyle. So all of you are kind of interested in that, and you know that when you get your interest perks up when you see on the med list that the patient's on an anticoagulant, because you know kind of really how dangerous it is. What we're going to concentrate on today is a little bit of an overview and talk mostly about the new direct-acting oral anticoagulants, or DOACs. You're all, now it's, let's see if I got to get now this thing is not working, so let's see if this works. No. Oh, we got a num lock on, just a minute. Okay, I have no disclosures. The DOACs are also sometimes called NOACs for novel, but then after a few years they became not so novel, so now we just call them DOACs for direct acting. So here are the topics for discussion, and you know, if there's a really pressing question you have, one of you raise your hand and we'll try to address it, because, you know, I can lead off into areas that are not as much interest to you and stay off theme, and we're trying to make this a clinically relevant talk. So we will talk today about warfarin and its advantages and when you might want to use warfarin or need or must use warfarin. And we'll then go over the pharmacology of the new anticoagulants, which is very important to understand in selecting which of these newer anticoagulants you want to use. Then we'll talk about the effectiveness or what these tests do to coagulation tests, so you know how to interpret them if you have a patient on one of these drugs. We'll talk about the effectiveness of these drugs in AFib and DVT by looking at how they do in clinical trials against warfarin. Then we'll try to summarize the advantages and disadvantages, and then we can get in later, if we have enough time, into reversal, or what do you do when it comes in the ED and you're bleeding and you're on one of these agents, or at least it's on your med list. You know, what do you do? So those are the kinds of things I wanted to talk about here. So let's talk about heparin. You know, IV regular heparin is not going to ever go away. It has some advantages that no other anticoagulants have. It's very fast in onset. You've got the patient anticoagulated the minute you give them a bolus. You know, so within 30 seconds they're anticoagulated. Its metabolism is still unclear, but it can be used in patients with advanced liver disease and renal disease. So it kind of evaporates out of the system in the body tissues and is metabolized. But that gives it a tremendous advantage in patients, the kind of patients we have that are very sick with advanced renal disease, dialysis, et cetera, et cetera. You have to give it by continuous infusion. We used to measure the aPTT. Now you all are learning how to do an anti-10A assay, which is going to be essentially the same assay that we use to measure the effect of most of these new direct oral anticoagulants, but not quite. They're all calibrated a little differently. So the slope of the curve for the anticoagulant effect is different. You're going to have to order a DOAC level, which will be measured using an anti-10A assay. So this heparin anti-10A assay won't tell you exactly how much of the newer agents you have on board. But heparin's a bit of a pain. You've got to keep readjusting it based on the anti-10A, and there's big intersubject variation. You can have a 90-year-old on 800 units an hour and a 22-year-old heavy male on 3,200 units an hour. So, you know, it takes a lot of oversight for that, but it's not going to go away. Warfarin has been around since the 30s when it was discovered. Stands for the Wisconsin Area Research Foundation, that found it as the agent in clover that killed all the cattle that were eating this sweet clover that had a lot of the coumarin in it. It's very cheap. You'll see this a little bit later. Very long half-life, 37 hours. So it takes a long time for onset of action, a long time to get out of your system. And that's good if you are long-term anticoagulation and you want a steady response. If you miss a dose, it's not the end of the world. Your INR is not going to bottom out. So that's a real plus, even though in someone who comes in with bleeding, it's a real negative because it takes a lot of different things that we have to do to reverse the effect of warfarin, including fresh frozen plasma, use of new Kcentra, vitamin K, et cetera. We can use warfarin in people with advanced renal disease on dialysis. The newer ones, we really can't, or there hasn't been a lot of data to indicate that any of them can be successfully used with a low incidence of bleeding. We could also use it in patients with liver disease, even though most physicians don't use it, especially when the INR is already elevated. But believe it or not, there's no good evidence that in liver disease patients with an elevated INR that they are self-anticoagulated. They still coagulate just as much as they do with a low INR. So something has to be done, and you'll probably be calling me, and what do I do with a patient with advanced liver disease and an INR of 1.8, and they just had, acute portal vein thrombosis, say. So that's a situation we sometimes find. So, but warfarin can be used in these situations, and these newer agents, there's a lot less data. I don't think I'll say too much about fondaparinux, which is the ultra-low molecular weight heparin and low molecular weight heparin. They have their uses, getting people out of the hospital quickly when you're putting them on warfarin or some of these newer agents. So we hustle them out of the hospital a lot faster. The half-life of low molecular weight heparin and most of these new DOAC agents is similar, about 10 hours. So if you give low molecular weight heparin twice a day, frequently the DOACs will be given exactly the same time interval, like Apixaban twice a day or Rivaroxaban. I guess Apixaban is once a day, but you could give it twice a day, or dabigatran is twice a day. And so going from low molecular weight heparin to the DOACs, you're just going to, at the time of the next low molecular weight heparin dose, start the new DOAC. Just kind of move from one to the other very readily. So the ideal anticoagulant we still don't have. We take it orally, no interaction with food, anything like that. It'd be fixed dosing, although we want the ability to potentially change the dose in certain circumstances. Can be quickly reversed. As you know, these newer agents, this has been a problem, that especially with the anti-10A agents, the Apixaban, Rivaroxaban, et cetera. There's no easy, quick reversal. They are affected by renal excretion, so you'd like a drug that doesn't have any effect. You'd like a drug with no major drug interactions. Sorry, they still have drug interactions with the newer DOACs that you need to know about. And that they're as effective as heparin, low molecular weight heparin, and warfarin, and we'll go over that data. Finally, you'd like it to be affordable. That's a really important point, because you're going to be relying on these people taking this medicine once or twice a day and not running out. And what if their budget's stretched and they have to shell out another $40 every month for their medicine? Or in some cases, I've seen the copay is $400, more than the cost of the drug. They're not going to spend their money if they're low on cash, and they may just stop it for a month and say, oh, well, I have AFib. I'm just a little low on cash this month, so I think I'll just hold off getting my medicine refilled. You'd also like it to be used in pregnancy, right, in patients with a mechanical heart valve, and we have no indication for use of anything other than heparin, and after the 12th week of pregnancy, use of warfarin as our only drugs. So what are these new anticoagulants? You see the list there. You're probably all familiar with them. The first one out was the dabigatran or Pradaxa. That is a direct antithrombin. And we'll see this, the coagulation cascade in a minute. So it's an antithrombin, direct antithrombin. You don't need any other cofactor like, that, for example, heparin in inhibiting it uses antithrombin. You don't need antithrombin binding to dabigatran. It just is a direct anti-2A. The others are direct anti-10As, and they're Rivaroxaban, Apixaban, Edoxaban, and Betrixaban. That's the most recently released agent. We'll talk a little bit about their pharmacology. And they're approved. One or more of these drugs is approved for treatment of AF, orthopedic prophylaxis, treatment of DVT, prevention of DVT. They are not approved for use in patients with mechanical heart valve or pregnancy. Any questions so far? Okay. You've been eating. You might be lulled into sleep, and go back to your schooling and remember the coagulation cascade. But just remember that I had little arrows here pointing to the sites where warfarin operates. So let's just do that. So it inhibits the synthesis of factor 2, prothrombin, factor 7, factor 9, and factor 10. So it's really lowering the level of the clotting factors. It is not actually an anticoagulant in the true sense of the word. It has no direct effect on preventing a coagulation problem, and you do see instances when in patients with a therapeutic INR, generally 2 to 3, do thrombose, especially when the impetus for coagulation is strong, like cancer, pancreatic cancer, et cetera. So you will hear of, gee, they had a thrombotic diathesis on warfarin. Well, they just have lower levels of clotting factors. Doesn't mean they can't coagulate. These newer agents are more directly inhibiting factor 10A or 2A, the thrombin and the anti-10A, and are more appropriately really deemed an anticoagulant. With the resonance, I liken The parallel I usually talk about is the barbecue in the backyard. You got a choice. You can pour water on it, which is giving an anticoagulant like one of the 10As, or you could shut the lid and cut off the oxygen supply. And that's more or less what warfarin does. You just lower the level of the clotting factors, and there are just not enough around to do it. But they work a bit differently, and that's important to know that difference. All right, here's the most busy slide, but probably the most important one. So let's just kind of walk through it. So let's talk about each of these. So dabigatran, right, is an antithrombin. It's direct. If we're going to go over this again a little bit later, so hit it twice. If you want to find out if it's in the blood, the best test is a dilute thrombin time or a thrombin time. It will have an effect, and if the levels are 0, the thrombin time will be absolutely normal. So we do have a test in the ED to see if the patient is on dabigatran, which is a thrombin time. Now, if they took an anti-10A, no help. So you have to see it on their med list and think that that's what they're taking. You can get an effect with the aPTT, so you might want to do that as well, and the Efficacy clotting time, which you probably don't even know what it is. It's released, and it's on the market, but it has very low bioavailability. Only 6 to 7% of it gets in your circulation. You have to swallow it with a big capsule, and if you press it and crunch it in the mouth, then it renders it the dose different, so you have to swallow the capsule intact. You can't chew the capsule. That's to swallow it, and then it's released right in the gut, and it immediately is working as an anticoagulant. It's a direct anti-2A. So we're going to kind of see and not be too surprised if you get a little bit more bleeding in the GI tract in people on dabigatran because you're anticoagulating whatever the drug touches. Peak time to concentration maximum is 2 hours. Half-life's a little bit longer than 10 hours, 12 to 14 hours. Nevertheless, they have prescribed it twice a day. They get lower peaks and higher troughs. So you're going to be giving it twice a day. It's renally excreted. So this is a big bugaboo with dabigatran. Your patients with AFib, they're on it, and as they get older and the renal function deteriorates, you may have to change the dose because it is renally excreted, and you really can't give it to anyone with compromised renal function. It does have drug interactions with P-glycoprotein and the cytochrome P3A4, which you all know immediately. All of the drugs that interact with that particular cytochrome system, and if you don't, you can call the anticoagulation clinic and they can tell you. So use that resource if you're not sure. And a lot of pharmacists, even in retail stores, don't keep up with all that, and that's a potential bugaboo with some of these new anticoagulants that do have some drug interactions. All the rest of them are pretty simple. They're all direct anti-10As, the Rivaroxaban, the Apixaban, the Edoxaban, and the Apixaban. But they're different. They're not interchangeable exactly. They're not so precisely the same. One is just as good as the other. So you got to know the subtle differences. So the Rivaroxaban has high bioavailability. It anticoagulates you fully within a couple hours. And just pick 10 hours as being the half-life. So if you want to get rid of the drug entirely, you got 5 half-lives, 2 full days with normal renal function. A little compromised renal function, 3 full days. We don't really know what level leads to an anticoagulation effect. All of the studies have all been done on fixed doses. So I don't know if it drops down to 30% of the peak that you're no longer anticoagulated. Nobody has any data on that. I have no idea how low you have to be off the anticoagulant. Unknown. It's given once a day. So its claim to fame was, gee, it's going to be simple, once-a-day drug. Well, that leads to higher peaks and lower troughs compared to twice a day, but it is associated in many studies with greater adherence, a once-a-day drug versus twice a day. So probably the most important takeaway is, yeah, Rivaroxaban's once a day. And it does have renal excretion, and I'm going to have to worry about the patient's creatinine as they get older, and we might have to drop the dose down. Apixaban took a different turn in the market. Its half-life is essentially identical to Rivaroxaban, but they did all the studies with twice-a-day dosing. So they wanted to lower the peak, raise the trough, give it twice a day, and maybe they'd end up with a better safety profile. Its bioavailability is very high, 87%. Time to peak, same as Rivaroxaban. Give it twice a day. It has less renal excretion. And in the package insert, it says you can use it in people with compromised renal function. You can use it based on pharmacology in patients with renal failure. But we don't have any data on people on Apixaban with renal failure to show you that it's safe. But the FDA says you can use it based on pharmacokinetics. So that's interesting, but shy away from it until we see more data on whether you really can do that. And you can see they still have drug interactions with both P-glycoprotein and the cytochrome system. And you need to know those medicines. In general, amiodarone is a big one. Verapamil is a big one for some of these drug interactions you have to keep up, and all HIV meds. HIV, don't put anyone on one of these drugs. Have our anticoagulation pharmacists do it once they're on steady state with any HIV meds. Edoxaban's another lookalike drug with a little lower bioavailability, about 40 to 60%, same time to peak, same half-life. They give once a daily, like Rivaroxaban. It has a little less, or 35% is renal excreted, so a little bit better profile like Apixaban, not so dependent on renal excretion. They got in the market late, and they did what, I didn't mention this, dabigatran and Edoxaban decided that they didn't want to take a chance in their trials in people with DVT of starting with the drug right off the bat. We're going to start with low molecular weight heparin and then just switch to the drug. So in the package insert, you can't start them on this drug. You have to use low molecular weight heparin for 5 days and then switch to these drugs. So that kind of put them a little bit behind the curve in terms of docs in the ED to starting someone with a PE or a DVT directly on these drugs. So their little way of getting into the market now is they're the first out. They just had a big abstract on treating several hundred patients with cancer-associated thrombosis and were as successful as dalteparin, the low molecular weight heparin. It hasn't been published yet, but it's been abstract presented. So they're going to try to hone in on the market a little bit, similarly to what dalteparin did. Instead of enoxaparin, in cancer patients use dalteparin because enoxaparin didn't spend the money on the cancer patients, but dalteparin folks did, and so that's the way it goes. So you'll hear more about Edoxaban for treating cancer-associated thrombosis. Now, Apixaban is out now, and they did a study to prevent VTE in high-risk medical patients. And they get these patients with crazy high risk factors. They're really sick as a dog, and sent them out of the hospital on Apixaban, which was started early in their hospitalization and continued for 30 days after discharge. Its half-life is 37 hours. Now, that's a long time, 37 hours. And if they start bleeding and we don't have any agent to reverse it, I think we're in really big trouble. The other agents, including Apixaban and Rivaroxaban, also looked at patients coming out of the hospital and putting them on prophylaxis and didn't quite achieve statistically significant results, so they don't have FDA approval, whereas in the Apixaban study, they did, albeit they did have bleeding complications. They reached a level of significance that allowed them to get FDA approval for this. So it's only out there for prophylaxis in hospitalized medical patients. What's really interesting is the manufacturer of this, Portola, is about to release a drug that can scavenge and pick up anti-10A molecules called Adexanet. We have no idea how much it costs, but they've got they've got the solution to how to treat people who bleed on Apixaban. You have to buy their other drug, Adexanet, that you have to give intravenously that binds up anti-10A, but it only does so during the infusion. If you stop the infusion, suddenly it goes away and the anti-10A still stays in your body and you're now anticoagulated again. So we think the cost for this new Adexanet is going to be very high. You have to continuously infuse it until all the anti-10A is gone, and it may cost in the order of $50,000 to $60,000 to put someone on this drug who's actively bleeding. So just an interesting background on the manufacturers of Apixaban. We don't have it on the formulary yet for prophylaxis in high-risk medical patients, and until we've got a really cheap, simple way of getting rid of the drug, I'm not sure I'd want to use it. So here's our old pharmacology slide showing the upper left-hand corner, the difference between Rivaroxaban and Apixaban, right? So once-a-day dosing, higher peak, lower trough, twice a day, a little bit more pain in the rear to remember to take it, but a little steadier dose. What's the effect of missing one dose? Look in panel B. If you miss a twice-a-day dosing, you get a minimal effect on the overall drug level as long as you get back to taking it. Whereas if you miss a Q-day dose of Rivaroxaban, which is C, you go pretty far down. Equivalent would be missing 3 doses of a twice-a-day drug. And it also shows the effect of an additional extra, I've forgotten I took it twice, once-a-day drug throws the peak up significantly higher. So here we got the pros and the cons. Which do you want to take? A once a day, easier to take and remember, or twice a day? Lower peak, higher trough, less of an effect if you forget a dose. And each drug company will argue that to your ear if you let them talk to you directly as to the benefits. We did a little study about adherence early on in 2014 in dabigatran patients. We got all of them that were on a managed care formulary, and we saw that their cardiologist put them on dabigatran for AFib, and we said, how often do they refill their meds? The mean possession time rate, the MPR, for the patients was 63% of the time they were taking the drug. And 43% of the patients had a mean possession rate of less than 80% of the time. So they'd run out of their script and not fill it for 20 days. Now, dabigatran's got a little bit of a problem, can give you some gastritis. These are the big capsules you have to swallow. Maybe it's a little bit harder. It was the first one out. The cardiologist didn't send them to our clinic to be educated. They didn't know that potentially that once they were off, they could have catastrophic stroke, et cetera. So other things may have fed into it. But you can see we have the potential of having a non-adherent patient population who's not taking their medicine, and they're right off the drug. Whereas Warfarin, we can measure it, and we measure their INR. Our pharmacy staff are on the phone with them. We know the names of their dogs, the names of their cats. We know when their relatives are in town. They call us about their sore throat and how to, so we're really friendly with the group, and that's great. We got a family out there, basically. I also know the sociopaths that we have on Warfarin. But we don't do that with the DOACs. They're just out there. They're going to stop it for 2 days, and, I'll show you some data that suggests why stopping it for a very short time may be close to catastrophic. Let's detect these drugs. So let's look in the upper left-hand side of this slide. You see on the x-axis the measurement of the DOAC using an anti-10A assay. Okay, so that's how we measure it, an anti-10A assay, but it's specific for each drug. And we're going to look at the INR on the y-axis. So dabigatran does affect the INR. Look at Apixaban. Doesn't do a thing. Look at Rivaroxaban. It does have an intermediate effect. That's what I'm saying. These drugs are not the same. They are not the same. These are effects in the test tube, so they're affecting the INR test, okay, and as a measure. You can see how different. Apixaban was about like Rivaroxaban. What about the aPTT, which is in the bottom right? So you can see that dabigatran has a pretty good effect on the aPTT, whereas the anti-10As don't. So your patient says, oh, they're taking Apixaban, you might have very high levels with a normal aPTT and a normal INR. So no bets are off. So we need to get, and we have drug level tests. You can order an Apixaban level, a Rivaroxaban level. They are anti-10A assays that are specifically constructed to measure the amount of those drugs between 8 in the morning and 5 at night, Monday through Friday. Oh, they came in bleeding at 10 p.m. Sorry, can't measure, don't do it right now. So we might have to come to that. So for dabigatran, we said use a thrombin time. You can see the little figure here showing that when the dabigatran level is 0, the thrombin time is 0. For all dabigatran levels, higher levels, it has an effect on the thrombin time. So a normal thrombin time, no dabigatran around. And if you want to quantitate dabigatran, instead of an anti-10A assay, we have a ecrin chromogenic assay to measure the level of the presence of dabigatran Monday through Friday, 8 to 5. So tell your patients if they overdose and get bleeding to come in during the day of the week. These just show how you have to calibrate the anti-10A assay for each of the drugs. And when you do, you get very good results with anti-10A measurement, but they're specific, calibrated for those specific drugs. There is a Comatic brand anti-10A that may become more widespread and used that says that they can pick up all of the anti-10As to some degree. And so if you get a very low level, this one shows Apixaban, this Comatic anti-10A also gets close to 0. Comatic is a brand that has this, their sensitivity set for low molecular weight heparin, but it also appears to be good at detecting the anti-10As. So what about the effectiveness of these agents? Dabigatran's been tested at 150 milligrams twice a day and 110, Rivaroxaban at 20 milligrams a day, Apixaban at 5, and Edoxaban at 60 and 30. Now, one thing I want to say, these guys have to have done a little research ahead of time on the dose, but when they finally decided to do these studies, this was the big plunge. Did they get the dose right? If they give too much, they'll get great efficacy, potentially, at preventing stroke or DVT, but they'll bleed. And if they're a little bit low, they're not going to do as well for stroke, and they're going to have less bleeding. So let's kind of see what we think from the studies of who might have picked the doses the best. On the other hand, they could be very, what's the best word? These drugs might be so good and so useful that the dose range is pretty wide, and we won't see much of an effect at all. Don't forget, in all these studies, all the entrance criteria for AFib or DVT, whatever you like, they're different in each of the studies. So you can't directly compare one drug to the other based on how they did in their randomized trial. The patients who came in, the CHAD score might be higher for one of the AFib studies of who they allowed in versus the other. Or they might have been longer on warfarin with prior DVT in one study than the other. So you just can't do anything except say the only way to really compare these DOAC agents is in a direct head-to-head, and none of them have offered their drug up for use in direct head-to-head comparison studies. We do have some real-world data to talk about it. Okay, here was this experiment that was done by accident by Rivaroxaban in patients with AFib in the ROCKET study. So the guy writing the protocol said, okay, on the day at the very end of the trial when they're really done, we'll stop the Rivaroxaban and we'll start the warfarin that day. The other studies kept them on the study drug while they started warfarin and overlapped, like you might do with IV heparin or something as you start your warfarin, right? So they did the experiment a little bit differently. So in the on-drug portion of the study, Rivaroxaban actually was significantly better than warfarin in preventing stroke. But when it was analyzed on intention to treat following their protocol, it was no different. And in fact, all of the strokes, you could see at the end in the lower panel, all of the strokes occurred at the end of the treatment period when they stopped the Rivaroxaban and put them on warfarin. Some of you may be really into warfarin and know that when you start warfarin, right, you knock out your anticoagulant proteins, protein C and S. So in someone who's got an ongoing tendency to clot, if you just start warfarin alone, you're hosed, right? It can drop protein C and S and you suddenly clot like mad, like HIT. HIT, you start to activate coagulation system with this HIT antibody, and you start them on warfarin, they'll just coagulate because you drop out protein C and S, and the anticoagulant effect hasn't occurred. Well, they stopped the Rivaroxaban, put them on warfarin alone, and multiple strokes occurred in the next 2 weeks. To me, that's a take-home lesson of, I don't know if there's rebound, but you're going to have to be very careful whenever we decide, even an AFib patient, to stop one of these drugs perioperatively or whatever. You stop it, especially, and maybe it's the warfarin effect though, and start warfarin. So actually, from the study design, you'd have to say you're most worried about stopping it without any overlap and starting warfarin, because that's exactly what they did. Whether stopping it alone leads to some kind of rebound, we're not so sure. Because they ended the study and they had to put them back on their regular drug. No, they were a clinical trial. No, that's what I'm saying. But in the real world, if you do it, the protocol is to start them on the warfarin, right, and wait until the INR is up to 2. Now, but the DOAC has an effect. Rivaroxaban has an effect on the INR. Apixaban doesn't. So you have to measure the INR in the morning, before you take your morning dose, where it's at the trough. So it has the minimal effect on the INR, so the INR measurement is the warfarin effect. And then the minute you blood draw to get the INR, then you can swallow your Rivaroxaban for that day. And you have to adjust it until you get up to an INR 2, and then you can not take the Rivaroxaban. It's a little tricky, right? Because you got to know which drugs are affecting what. Here are some what they call forest plots. Let's focus only on the right-hand side of all these slides. On the left-hand side are the effects of these drugs in older individuals. On the right are the effects of these drugs in a whole lot of different clinical studies. So in this one, we're going to look at the prevention of stroke in people with AFib. So here's the odds ratio, P/odds ratio of any difference between warfarin and dabigatran in multiple studies. So these are little meta-analyses. And you can see that dabigatran was, so anything down here at the bottom that says favors the DOAC. On the left-hand side, anything to the right of that line favors warfarin. So dabigatran led to a significant reduction in the incidence of stroke compared to warfarin at 150 twice a day. At 110 twice a day, there was no difference. Rivaroxaban, slightly lower incidence, not statistically significant, because the 95% confidence interval was 1.0. So you couldn't say it was a little different. Apixaban, the confidence limit was 0.94, so it did significantly lower the risk of stroke. But you can see pretty good evidence that they're at least equivalent to warfarin in terms of stroke reduction. Edoxaban was very similar to Rivaroxaban. It's 60 milligrams a day, but look what happens with the dose. They got edoxaban 30 versus 60. If you gave only 30 of edoxaban, it was actually worse. So you got a little bit of an idea that the dose does make a difference. Okay, so Apixaban, we only had the 1 5 milligram dose for that. So what about treatment of acute DVT? Dabigatran at the dose of 150 was equivalent to warfarin. Apixaban, a little bit better. Rivaroxaban, a little bit better. Edoxaban, a little bit better. And all of them are about the same in their full dose. Okay? So what about bleeding in both patients with AFib and DVT? Dabigatran overall in the population had a little less overall bleeding, a little bit less bleeding at 110. Rivaroxaban, not much difference. Apixaban had significantly lower rates of bleeding overall. Lower rates of bleeding with Apixaban compared to Rivaroxaban. So did Edoxaban at 60. So did Edoxaban at 30. And they had even significantly less, right? So Edoxaban is doing exactly what you expect. At the 30 milligram dose, less effect on stroke, much less bleeding. So that's too low a dose. So dose does matter. So if you go to the Edoxaban dose of 30, you get less effectiveness, less bleeding. So that's pretty interesting. Now let's look at all the bleeding. Let's do the whole study population here. For GI bleeding. Now GI is special, right? You got the dabigatran, it's sitting right in your stomach lining, immediately anticoagulates, and indeed the dabigatran, it had more bleeding compared to warfarin. So warfarin was favored versus the dabigatran, and also true with Rivaroxaban for GI bleeding, whereas Apixaban was a little bit lower but not statistically significant, and Edoxaban 30, definitely lower rate of GI bleeding. What about intracranial bleeding? This is going to be on all the board exams, right? Because this is a big selling point. These DOACs, for some reason, do a tremendous job at preventing or not being associated with intracranial bleeding compared to warfarin. Now, what could be going on there? Does anybody have any ideas why intracranial bleeding, and this is subdurals as well as acute intraparenchymal hemorrhage, why warfarin is so much worse than these DOAC agents? Well, nobody knows, but it's pretty interesting. You know, you drop, first of all, you want to repair a little rent in a capillary, and what happens when the capillary has a little rent, you activate tissue factor. Tissue factor immediately acts on factor 7, and you start to form a plug. Warfarin doesn't have factor 7. You inhibited it. Whereas the DOACs, you have all the factor 7 you want. All you're doing is inhibiting the cascade. So people think it's because you have low factor 7 in patients on warfarin, and they have a higher rate of intracranial bleeding. And I'm taking most of my elderly patients who are getting up to 80, and they might trip and fall and all, I'm switching them to one of the DOACs instead of warfarin. I mean, this is an impressive 60% reduction in intracranial bleeding with the DOACs compared to warfarin. So, and it makes a difference there. So this is a bigger selling point for those, especially in the older AFib patients. For clinically relevant bleeding, which is, you know, you do something, you have to reverse them and do endoscopy and, you know, something that required some input. They all had a significantly lower rate of bleeding compared to warfarin. So they had a lot of minor bleeds with the other, but when you had a clinically relevant bleeding, the DOACs had overall less. And what was interesting, this to me was fascinating. Remember, Apixaban had the best appearance of bleeding, the way they defined it, of all the DOACs. But it had the least in terms of fatal bleeding. It showed no statistically significant difference. Whereas the others, for dabigatran 110, Rivaroxaban, and Edoxaban, all showed a significant reduction compared to warfarin in fatal bleeding. So, interesting. So you can see, so there's a little more GI bleeding, probably with the DOACs, especially dabigatran and Rivaroxaban. but a lot less intracranial bleeding, and overall less clinically significant bleeding and better mortality, or fewer deaths due to bleeding. So I won't summarize that. I've shown that all to you. For dosing, then we'll just run through some of that and then answer some of your questions. So if the creatinine clearance is above 30, you can use the Apixaban 150 milligrams twice a day. If it's 15 to 30, it's renally excreted. You got to lower the dose. 75 milligrams twice a day, so you got to follow the creatinine clearance and do your Krakow-Gault calculation. If the creatinine clearance is very low, don't use it, right? Less than 15 cc's. Avoid it. Do not use it in dialysis patients. Don't use it. So VTE for dabigatran, it set it up in such a way that it started low molecular weight heparin and moved to dabigatran. So you can't start your patient on dabigatran for an acute VTE, at least according to the FDA package insert. You have to start with low molecular weight heparin and move them on to dabigatran after 5 days, because that's the way they did the studies. So it's not approved for initial use. Okay, you got to check the creatinine clearance and adjust it. Don't forget they have significant drug interactions. How about Rivaroxaban? It's good to go at, for orthopedic procedures, it's approved at 10 milligrams per day. And for maintenance, it just came out last May. Let me talk about that. For both Apixaban and Rivaroxaban, after you treat an acute VTE for 3 to 6 months at the scheduled full dose, you can go to a lower dose to prevent VTE thereafter. So they've done studies where, for example, they take Apixaban 5 milligrams twice a day, they go for 6 months, and now they continue half the patients on 5 milligrams twice a day, and the other half they put on 2.5 twice a day. The incidence of bleeding and VTE is identical in those two groups. So you can drop the dose down. Do you get lower bleeding? They didn't in the clinical trials, but you hope that a lower dose is associated with less bleeding. They didn't. They got exactly the same bleeding rate, exactly the same VTE prevention rate. So once you have them on the full dose, you want to go cut it down in half at the end of your, quote, treatment period, 3 to 6 months. Rivaroxaban just came out with a study last May where they went from 20 milligrams a day down to 10. So the long-term venous prophylaxis dose is 10 for Rivaroxaban, 2.5 twice a day for Apixaban, and it's going to be the lower dose for Edoxaban, the 30 milligram dose for Edoxaban. So since Rivaroxaban is a little bit more renally excreted, you are going to have to watch it like dabigatran. It's going to be for AFib 20 milligrams a day, once a day is your dose, but if their creatinine clearance is between 15 and 50, they want you to drop it down to 15. So things get a little bit more complex when you get into the nuances of exactly what you're treating and exactly what their creatinine is. For Apixaban, VTE prophylaxis is 2.5 milligrams twice a day. AFib and VTE treatment, 5 milligrams twice a day. So that's the full dose is 5 milligrams twice a day. Now you have to add, by the way, for acute VTE, you have to give 10 milligrams twice a day for the first 7 days. I didn't mention that, so let's go back to Rivaroxaban. For Rivaroxaban, for the first 21 days, you have to give 15 milligrams twice a day, 30 milligrams. Why did they do that? Well, they just thought in the acute DVT situation, you needed more anticoagulants. So that's what they did. So now you get packs that come out for Rivaroxaban, where they get 21 days with 2 tablets, 15 milligrams each day. And then after the 21st day, they have 20 milligram tablets. That's really good because last year we had a patient who came back after being treated for acute VT with Rivaroxaban, and I said, did you take your medicine as prescribed? He says, yeah, I took 50 milligrams a day. I took 2 15s and 1 20. So they got confused. And all of you are confused right now. You're going to, wait a minute, what is it? See, the creatinine is this, and then it's that. So for VT, it gets a little complex. You start at a higher dose, 7 days for Apixaban, 21 days for Rivaroxaban. then drop down to the maintenance dose, and then after 3 to 6 months to the prophylaxis dose. And you got to get all those doses straight, and you got to make sure the patient understands it, and you're sending them out of the ED, and they're not stressed at all. They're going to remember every word you say, right? But at least for Rivaroxaban, they put it all in bubble pack, where take it exactly where it says you can take it. So that might be better. But you can see as they come out how they're going to get confused, or what if they think, oh, yeah, a lot better after 4 weeks, I'm going to quit. And these are the issues we have. We don't know what goes on. They send them out of the ED, and are they taking it after a month or not? So we're trying to upgrade our anticoagulation clinic to try to find these people and educate them and at least see them back once. Apixaban, not used that much. It's going to be, the only really interesting thing was the FDA made them put a proviso in that says you can't use Apixaban if their creatinine clearance is over 95 for treatment of AFib. And the reason was that they got exactly the same stroke rate all the way down to different creatinines. But Warfarin had a very low stroke rate if their creatinine clearance was greater than 95. So compared to Apixaban, the FDA says, nope, you can't recommend it with a creatinine clearance greater than 95 because Warfarin's better. So you're going to be scratching your head, why with good renal function I can't use the drug? Well, Warfarin was a lot better, and they're the only one who looked at it. The other ones didn't look at that. So, you know, lots of craziness out there. They go down to the 30 milligram dose when you're in the 15 to 30 cc's per minute creatinine clearance. So Rivaroxaban and Edoxaban, once-a-day drugs. If the creatinine clearance drops to less than 50, you go to the lower dose. For treatment of ET is 60 milligrams once a day, and the prophylaxis dose is 30. If the creatinine clearance is low for VTE, you could use 30 of Edoxaban. You're going to see that more and more. It's a little cheaper. There have been some studies that looked at the real world. In fact, I'm just going to have a couple more slides and we'll quit. 62,000 patients in Denmark on an oral anticoagulant looked at the risk of stroke, and it didn't differ between the DOACs and Warfarin. Looked at the cause of death and bleeding, etc. They were significantly lower with dabigatran and Apixaban, but not Rivaroxaban. For risk of death, any bleeding or major bleeding. For intracranial bleeding, it was significantly lower with dabigatran and Rivaroxaban, but not Apixaban. Apixaban was the one that had the lowest rate of bleeding. And it had, so it's kind of really crazy what these reports are. But where we get the idea that the clinical trials can be applied to the population. Overall, it does reduce the risk of stroke, but there's some nuances that pop out where Rivaroxaban wasn't quite as good for preventing the ultimate catastrophic death, major bleeding or any bleeding. Apixaban did less well for bleeding. In general, the real-world studies suggest these agents are pretty good. Don't forget the drug interactions, cytochrome P453A4, and all ketoconazole, all the ritonavir and HIV meds, clarithromycin and erythromycin interact with those. Other ones are carbamazepine, tegretol, phenytoin, rifampin, etc. Especially for dabigatran, you got to worry about amiodarone and verapamil. For switching the DOACs, do you want to get into that or not? Is that something that maybe we'll make this the last slide then? So you're switching. We're going to go line by line. You got them on usual IV heparin. Okay. What do? You just turn it off and start the DOAC. That's it. Right? Takes hour and a half, half-life, 3 hours for the heparin to go away, 2 hours for the DOAC to come on. So turn off the heparin, give them the DOAC. Low molecular weight heparin. Well, it has a half-life of 10 hours. So at the next dose of low molecular weight heparin, you start the DOAC. And you stop the low molecular weight heparin. Right on key. Same twice a day. Or if you go to once a day, that's when you start the Rivaroxaban. From Warfarin, you first let the INR go down below 2 on warfarin, and then start the DOAC. Are you kind of doubly anticoagulated for a while? Probably. But that's the recommendation. Once the INR drops below 2, start the DOAC. So what if you're going from an anti-10A to usual fractionated heparin? Okay. Well, you hold a few half-lives if they're on full dose, and then start the infusion, so 20 hours. So 2 to 5 half-lives. 20 hours to 50 hours, you wait, and then you start your IV heparin without a bolus. If you go from an anti-10A to low molecular weight heparin, same thing, 2 to 3 half-lives, and then start your low molecular weight heparin. I said infusion, it should be injection. What about an anti-10A to low molecular weight heparin? You wait 2 to 3 half-lives, about a day, and on cue, you start your low molecular weight heparin. So again, if you're on daily Rivaroxaban, you just wait for it to go away and start your low molecular weight heparin. Just exactly the opposite. And the anti-10A to warfarin, that's the toughest. You have to keep measuring your INR, wait for it. You know, you start your warfarin, and you got to measure your warfarin INR at the trough. It's not a problem with the Apixaban because the Apixaban doesn't affect the INR, but it is with Rivaroxaban. Yeah. Yeah. To do what? Okay. Yeah. Just like if you give them a shot of low molecular weight heparin, it's just like giving them a dose of the anti-10A. Well, you know the half-life of the drug, about 10 hours. So you know it's 5 half-lives or 2 days, 2 full days. So you do the procedure Wednesday morning. They don't take it on Monday and Tuesday. And they do it Wednesday morning. You're going to have a low level. But you got to know what the creatinine is, because the creatinine is like 1.3, maybe. So we generally say you got to wait 3 days. If they've got any suggestion that they've got some renal insufficiency, you have to add another day. But really, we don't even have any studies to know whether we're going to get into trouble when they get down to those low levels. We don't know. We don't know if they bleed or don't bleed. It probably doesn't make a big difference. At least we don't have any studies to help guide us now. If it did, if we had a rapid thing and we knew that level of 20 nanograms per ml or less, they don't bleed, you probably have it. You probably have an on-site machine to measure it, and you go, I feel really good. We don't have that data yet. So we're just by guessing by golly right now. What do you do with it? It had DVT 3 weeks ago. Well, we never like to stop our anticoagulant, but sometimes we have to. So it's a lot easier to put them on a DOAC, stop that. Sorry, I gotta start talking on the microphone. It's a lot easier to have on a DOAC and stop it than to be on warfarin. And then for warfarin, you're going to have to let it drift down. The minute it gets below 2, you start IV heparin in very low doses. You know, I mean, that takes days in the hospital, et cetera. I think you just better call us up and kind of work on what the best strategy may be in a given patient. Yeah.